Good afternoon, everyone. My name is Amy Lunkin, and I'm one of the clinical educators at the Lindner Center of Hope. Thank you for joining us today for the Grand Rounds presentation, Harm OCD, a subtype of obsessive compulsive disorder. We are very pleased to have Kelly Corte as today's speaker. Kelly is the OCD and anxiety specialist at the Lindner Center of Hope. I have just a few housekeeping items before we begin. Please make sure your camera is off and your microphone is on mute. Today's presentation is being recorded and will be placed in the Learning Library for Lindner Center of Hope employees to view at a later date. Please note that if you are viewing the recording of the presentation, it is not eligible for continuing education credit. You must be in attendance for at least 45 minutes of today's presentation to qualify for CEU or CME credit. Please return your completed evaluation form within 7 days. Program evaluation form was attached to the invitation you received. If you are unable to locate it or can't open it, please put your email address in the chat today, and I will send you a copy of the form following the presentation. Today's presenter asked that we hold questions until the end of the presentation. We have quite a bit of material to cover. I will also be monitoring the chat box as questions come up throughout the presentation. If we don't have time for the presentation, or excuse me, for questions at the end, I will collect those questions and get them to Kelly, and we will get back to you following the program. So I'd like to turn it over to Kelly for the presentation.
Thank you. Hi, everyone. I'm Kelly Corte, as Amy had mentioned, and I wanted to start off with sharing some important upcoming OCD dates. So first of all, today is Pandas Awareness Day. So I'll talk about that in a moment. We also have the A Million Steps for OCD Walk, which myself and the rest of the Lindner Center OCD team hold, and that'll be this weekend. And next week is OCD Awareness Week, and then there's also an upcoming IOCDF online virtual conference. And for those unfamiliar, that's a really good place to get information for people who are either living with OCD or have family members with OCD, or for therapists who work with OCD. So I wanted to do my part to shine a light on Pans and Pandas. There's a campaign which is going on. It's called Light Up for Pandas, or Pans, excuse me, and World Pandas Awareness Day is today. So the campaign is basically using two colors to represent its mission and the struggles that families face and sufferers face that are impacted by pans and pandas. And out of 133 global landmarks around the world that are participating in that today, we actually have one in Cincinnati. It is the Paycor Stadium, and it's going to be lit up in green to participate in that today. So just for those of you who might not be familiar with PANS and PANDAS, I wanted to quickly just share what it is. PANS is pediatric acute onset neuropsychiatric syndrome, and PANDAS is pediatric autoimmune neuropsychiatric disorder associated with streptococcal infections. And both of these conditions involve a misdirected immune response attacking the brain, leading to changes of behavior regulation, emotions, and motor control. This response can be triggered by infections, environmental factors, or stress. And symptoms tend to be sudden, but are sometimes gradual. And they're listed below. Please check out the below resources if you have any more desire to learn more about it. All right, so Harm OCD, that's what we're here for today. So let's get into it. So the learning objectives are to identify symptom presentation of harm OCD, to differentiate harm or suicidal OCD from suicidality and suicidal ideation, and to also identify tools and techniques when working with harm OCD. So I think it's important to share why this topic is important. There's a general lack of understanding not only about OCD in general, but also harm OCD. Um, it may lead to misdiagnosis if it's not understood, and I've actually
Sorry, you're muted in case you don't know.
Hello, hello. Hello, hello. No one can hear you. You're muted.
Can everyone hear the presentation now?
Now we can.
hello.
Can hear you, Amy.
Yes, thank you.
Okay. All right. Thank you. Thank you. It looks like we left off with leading to misdiagnosis. So I apologize. I'm not quite sure how we got muted there. So where should we? Let's go back to. Stop sharing for just a second. Screen share. Let's go to this here.
Okay.
In almost 100 years. In Tampa specifically, I'm glad Gary is evacuated because Tampa Bay itself is only 11 foot
Okay.
deep, which means.
Can everyone hear me?
Yes.
Yes.
Yes. Okay. Excellent.
All right, sorry about that. So going back to diagnosis of obsessive compulsive disorder, obsessions are unwanted, uninvited, intrusive thoughts, images, feelings, and urges that trigger strong fears of substantial distress. Compulsions are repetitive behaviors or mental acts that the individual feels driven to perform in response to an obsession. So these are aimed at preventing or reducing anxiety or preventing some dreaded event or situation from occurring. And they are not always connected realistically with what they are designed to neutralize or prevent, and they tend to be clearly excessive. And so, in general, compulsions are meant to or do temporarily decrease distress. So a good way to differentiate obsessions from compulsions is to remember that obsessions increase anxiety and compulsions are an attempt to reduce or prevent anxiety. And then I just want to note that OCD symptoms are ego-dystonic, meaning that the thoughts and behaviors that they're engaging in are directly in conflict or dissonant with a person's values or how they see themselves. All right, so intrusive thoughts. We can't talk about OCD without talking about intrusive thoughts briefly. So intrusive thoughts, we can't pick and choose our thoughts. Everyone has intrusive thoughts because of that. Therefore, thinking violent thoughts is normal, and there are various theories as to why we have violent intrusive thoughts. However, that's something that I'm not necessarily going to get into today. But so with intrusive thoughts, we can't choose or control our thoughts, and so therefore they're not necessarily inherently meaningful. And it is important to note that thinking violent thoughts is not being violent. So with the non-OCD brain, it tends to be able to filter out an intrusive thought as like, oh, that's weird, that's odd, and kind of move forward. However, someone with harm OCD might have the same intrusive thought and it gets stuck, meaning that they'll say, oh no, this means something, I better be careful, or I better do something about this. So in general, with OCD, you notice and you worry that you noticed. So those with OCD might confuse paying attention to the presence of their thoughts with importance of the thought, and might even attach special meaning to the thought rather than just assuming that it's the spam email of the mind, which it is. And this tends to really lead harm OCD sufferers to experience a lot of shame, a lot of feeling misunderstood, self-blame, and even self-stigma. All right, so here's the OCD cycle. So we start with an obsession. So maybe I have an intrusive image of stabbing someone. This leads to increased distress. I'm feeling uncomfortable or anxious, and this leads me to feel like I really need to act on this right now to get rid of this thought or feeling. So then that leads to a compulsion. So let's say maybe I do some type of neutralizing behavior like leave the room or hide the knives or tell myself I would never harm someone. So then that leads to temporary relief. However, it is only temporary, and that's a big part of why this cycle does not work. It's not effective in the long term, because obsessions are reinforced and, OCD is strengthened for the future. So what is harm OCD? Harm OCD is a subtype of OCD that manifests primarily as intrusive thoughts about behaving in a way that would purposefully or unintentionally cause harm to oneself or others. And I do want to note that with OCD, a lot of times with the subtypes, there are common presentations and they tend to be categorized by either one's unwanted thoughts or their compulsive responses, just so that way we get a quick glimpse of this is more specifically what the OCD that this person is struggling with looks like, because it does look so different for everyone. So there are 4 manifestations of this, 4 main ones anyway. So fear of having a harmful identity, fear of impulsively harming others or losing control, fear of self-harm, and fear of harming children. And I just want to note that there tends to be quite a bit of overlap with these. However, I do think it's helpful to separate them out just for ease of being able to identify each of them a little bit better, because even though they look similar, there are differences to them as well. So for example, it is possible to have both a fear of self-harm and fear of harming others. All right, so the first subtype that we're going to talk about is fear of having a harmful identity. So this is mainly categorized by a fear of unintentionally harming others through lack of vigilance and fear of being a bad or harmful person. And OCD sufferers with fearing a harmful identity tend to struggle with uncertainty about what their intentions were or are. They tend to have unrealistic expectations for being good and not doing harm, and they tend to really set their standards exceedingly high for being good. And it tends to be in terms of certainty, even if it's not possible to be certain about it. All right, so what does this look like as far as obsessions? So obsessions with fear of having a harmful identity, we have harming others by lack of vigilance or negligence. So an example would be maybe fear of poisoning others with expired, unsafe, or improperly cooked food. It could also be unintentionally exposing a loved one to inappropriate content. Fear of harming others by not being careful enough. So an example of this might be leaving dangerous objects around or seeing a loose nail that could cause a structure to collapse and not saying anything. They also have fear of harming others emotionally. So saying the wrong thing maybe, or hurting someone's feelings, offending someone unknowingly, or inadvertently getting someone in trouble. And then also fear of harming others by contributing to global or large-scale problems. So this might look like buying an article of clothing which might have been manufactured unethically or maybe by children. All right, so common compulsions in fearing a harmful identity. So all compulsions for harm OCD tend to be similar throughout the different subtypes. So I plan to focus less on those moving forward, as many of them are the same, but they might have slight differences. So I'll try to point that out when it's applicable. But for this specifically, common compulsions are compulsive reasoning. So like thinking about or debating in your mind, didn't I hurt someone? Could I hurt someone? Mental review of past acts, conversations, or thoughts. Testing to see maybe if someone likes harmful thoughts. avoiding, lots of avoiding. So in this case, it might be avoiding objects which could unintentionally or intentionally cause harm, such as, maybe avoiding driving a car as someone might run over a pedestrian. Avoidance of media, especially true crime or news. Avoidance of situations, especially if there's a responsibility for protecting others. So maybe like visiting a hospital or avoiding babysitting. Avoiding emotional states, which could lead to harm. So maybe avoiding someone who makes you angry or makes you feel like you've lost control. Neutralizing with safe or clean thoughts. Excessive checking to make sure harm hasn't been done or couldn't be done. Seeking reassurance is such a big one. So it's either from others or from the internet, perhaps. So this could look like, am I a good person? It could also look like taking a psychopath test or looking up signs of being a serial killer. And then also confessing bad thoughts or acts. All right, so the next subtype of harm OCD is fear of harming others. So this is categorized by fear of losing control and acting either on impulses or on violent, intrusive thoughts. And these OCD sufferers tend to interpret intrusive, violent thoughts as motivated intentions. They tend to struggle with uncertainty about impulses being under control. They tend to hyper focus on impulse sensations. So like maybe if they're looking at a knife or something, paying extra attention to if someone has tingling in their hand, that might indicate that they want to grab it and stab someone. And they typically tend to feel like they're a ticking time bomb. So common obsessions and fear of harming others. This is not an exhaustive list, but a lot of these obsessions start with what if. And I think that's because the fear is about impulsively harming someone, perhaps seemingly out of nowhere. So the possibilities are kind of endless. I'll share a few of the more common examples I've personally seen when working with people. So some of the more common ones I've seen are what if I respond? No, I'm sorry. What if I push someone into danger? So maybe this is like pushing someone into the street when a car is going by, pushing someone onto a subway platform, or maybe even off of a ledge. What if I am suddenly inspired by something I see to commit a violent act against someone? So that's maybe like reading the news and acting on it. And what if someone causes me to become angry and my anger is uncontrollably expressed through violence? All right, common compulsions and fear of harming others. One that stands out is a little bit different from the rest of the compulsions with harm OCD is, especially with this one, it seems that there's quite a bit of attempt to prevent harm from occurring or making it more difficult to occur. So this might look like locking oneself in their bedroom or maybe even like setting up elaborate traps. Just to make sure that, someone maybe doesn't leave their bedroom without realizing they're leaving. But then we also have avoidance again of objects, weapons. We have avoidance of violent contact, even if it's slight. So like cartoons, avoiding emotionally charged situations such as confrontations, conflicts, situations. So specifically for this, being alone with those who might be deemed a potential victim. Confessing thoughts, urges, or perceived impulses. So it's important to note too with this one that sometimes people tend to compulsively warn others by confessing their thoughts and urges. And so it's kind of a way of like, hey, make sure that you stay vigilant because I'm feeling like I might strangle you. Just as an example. Reassurance seeking, same with the rest, neutralizing thoughts, and testing to see if having like impulses and or if someone will like it. All right, next subtype, fear of self-harm. So fear of acting recklessly and harming self unintentionally or purposefully. So OCD sufferers tend to struggle with uncertainty about losing life by accident, out of impulse, or with intention. They really tend to feel isolated and not talk about their intrusive thoughts, as others may assume that they're suicidal. And this, of course, is something which tends to occur in treatment, especially because, when someone is telling us that they're having suicidal thoughts, we tend to ask them or screen them in some way for their suicidality. And this part of this is even maybe asking if they're sure if they can be safe or contract for safety. And although that's a necessary thing to do for safety, please just also understand that asking someone who has self-harm OCD if they're sure they can be safe is incredibly hard for them to answer, as their OCD leads them to feel really doubtful, unconfident, and uncertain about this. So you might get a no as an answer just because they don't know. OCD sufferers of this kind also tend to have similar OCD fears related to fear of emotionally harming others. All right, so some common obsessions. Again, I'm just going to point out some of the ones that I've seen personally. So I may snap and impulsively cut myself with a knife, turn my car into oncoming traffic, jump off a ledge, overdose on medication. I may become suicidal by being alone for too long, letting myself experience sadness or stress, or letting myself be exposed to things that are upsetting. All right, self-harm compulsions, again, tend to have a lot of avoidance. I'm going to kind of skip through some of this just for time. There's thought neutralization, mental rituals, to try to be certain that they won't harm themselves, testing and checking that they won't complete self-harm actions or don't feel like they want to do it. So this one is definitely something I want to point out. It can be tricky because those who struggle with harm OCD sometimes might engage in self-harm or what look like perhaps like suicide attempt acts, just to see if they will complete it or not, or to see if it feels right when they're doing it. So yeah, this goes back to, well, we're going to talk about it in a little bit, but just the importance of assessment for this. There's also seeking reassurance, and about this is there is a tendency, especially with those who fear harming themselves, to compulsively seek monitoring. So like maybe having a video camera on them at all times at home, or going to inpatient possibly, so that way people are checking on them all the time, and then confessing. An additional note about suicidal thoughts. Sometimes suicidal thoughts can have other functions outside of true suicidality for OCD sufferers. So thinking about suicide can be a compulsion, and part of it might not even necessarily be fully intrusive, but some examples of this would be thinking about suicide as a way to avoid thinking about one's obsessions, or thinking about suicide as a form of self-reassurance. So maybe if you're worried that you're going to kill someone, kind of just telling yourself that you'll be able to get out of that if you just kill yourself instead of killing others. All right, the last subtype, so fear of harming children. There's two parts, but they're pretty much the same. Fear of harming children and postpartum OCD. So postpartum OCD is more specifically about fear of harming like one's own child or themselves within pregnancy, upon or after their birth. And those who have this form of OCD tend to struggle with uncertainty about harming or maybe even not protecting their children. And it's also worth noting that these people who have fear of harming their children tend to be the ones who really care a lot about their children, as OCD attacks what's most important to us. So again, pointing out which ones I've seen specifically when working with this population. What if I kill or physically harm my child by any of these kinds of ways? What if I may have harmed my child and don't know it or blocked it out somehow? What if I will never be comfortable with or will always resent my child? And what if I harm my child by being inappropriate with him or her, sexually or otherwise? And this one brings up a really good note too. So sexual harm is also considered harm OCD. So it shares territory with harm, even though it might seem a little bit different. All right, compulsions, more avoiding, especially of situations. So like maybe being alone with one's own children or children in general. So, maybe not taking care of them alone or bathing or dressing them alone, maybe not wanting to be around schools, parks, or other places. Mental review, reassurance seeking, again, confessing, and repeatedly checking to make sure no harm has been done. All right, so part 2, assessing and differentiating harm OCD. So assessing versus screening. Assessment is more in-depth than screening. Screening is a quick way to identify a patient's risk of suicide in the future. When to assess versus screen differs. However, assessment should occur at the beginning of treatment and at various points throughout treatment. And both assessment and screening have evidence-based tools which can be used. And I wanted to specifically point out more regarding the assessment portion. So John Hirschfield has assessment questions for harm OCD, which he has specifically created in his really great book. It's at the end of this PowerPoint. But basically, you want to ask specific questions about one's fears, and it's important to remember that none of the following questions answers are necessarily deal breakers, but careful examination of the answers is absolutely important for treatment. All right, so here are some questions for assessing for safety when someone appears to be fearing a harmful identity. I'll just maybe say one or two. Do you voluntarily fantasize for large amounts of time about your violent thoughts coming true? Do you wish you could get away with acting out on your violent thoughts? Assessing for safety when fear of harming others. Here are some more questions. So, do you have a history of engaging in violent acts? Do you have a historical pattern of resolving your differences through acts of violence? And I wanted to note it's also encouraged by John Hirschfield to, during this assessment process, collect information from family members who can objectively verify the answers to those questions. All right, assessing for safety when fear of harming children. So just some examples. Do you use physical discipline in your household? And if so, specifically how? Do your unwanted thoughts present themselves as thoughts, commands, or voices? And lastly, assessing for safety when fear of self-harm. So do you have a committed desire to harm yourself? And if so, what is your specific reason behind it? Do you have a specific plan for harming yourself? Is there a specific point in time that you imagine doing this? And there are others there as well. The idea is just to build a 3-dimensional picture of, one's mental and emotional status, and to make an educated assumption about safety, at least with these questions. But again, more assessment, of course, is encouraged. All right, so I want to actually focus a little bit more on the differences between suicidal obsessions and true suicidality or suicidal intent. So before I do this, though, I want to just draw your attention to the important notes. So in contrast to other types of suicidal ideation, suicidal obsessions, by definition, do not reflect an actual intention or desire to hurt oneself. That's important to remember. And also, it is possible for someone to have both suicidal obsessions and suicidal ideation. And I just also wanted to note that I know there's a lot of information here, so if you want this or the PowerPoint, put your request in the chat and Amy will get back to you. And then one last important note before I go through this, it is important to note that although I have a specialty in OCD, I'm not an expert on true suicidality. Okay, so with suicidal obsessions, like we already talked about, thoughts are unwelcome, unwanted, intrusive, about losing control, acting on thoughts, hurting oneself. With true suicidality, it's more intentional, voluntary, deliberate. And one can even think about suicide when they want to. So, that tends to not necessarily be all the time. So it can kind of be brought up when they would like to think about it. Suicidal obsessions, suicidal thoughts are anxiety inducing, and sometimes feared implications of having suicidal thoughts are worried about. So like, maybe because they're having these suicidal thoughts, they're worried about being bad, becoming depressed, worried about becoming involuntary hospitalized. With true suicidality, suicidal thoughts do not typically produce anxiety about death. Suicidal obsessions, thoughts are experienced as external and threatening, and they're not comforting or relieving to think about, which is contrary to true suicidality. So it's more experienced as internal and consistent with desire that someone has, and they may even feel relieved or comforted by thinking about like ending the suffering, for example. Back to suicidal obsessions, they may be inconsistent with current mood. They may lead to feelings of guilt. And then with true suicidality, it's often mood consistent and may be associated with hopelessness, despair, and feeling as if one's a burden. With suicidal obsessions, uncertainty is about the possibility of losing control, acting against genuine wishes, or the meaning of thoughts. So you might even hear them say something like, do I really want to act on my thoughts? Whereas with true suicidality, there's more uncertainty about whether to act on the thoughts. And they're more likely to have a history of suicide attempts or self-injurious behaviors. Suicidal obsessions tend to be based in fear and desire to protect self from harm, aka they don't want to die. And with true suicidality, it's based in some desire to die. And lastly, suicidal obsessions tend to lead to, not lastly, sorry. Suicidal obsessions tend to lead to a lot of avoidance, so hiding knives, not being alone. With true suicidality, it may lead to developing a plan, gathering materials. And now lastly, suicidal obsessions tend to talk or try to talk about intrusive thoughts with trusted others. And there's often what if language used. And with true suicidality, they tend to avoid talking about a plan or suicidal intent with others as to not be stopped. All right, so part 3, tools and techniques for working with harm OCD. So when working with harm OCD, when working with harm OCD, it's important to communicate confidence in one's ability to cope. So you want to avoid rescuing the patient in general or the person in general, whomever they might be to you. It's helpful to provide cues for using skills, tools, and techniques. And an important note about this, when I'm talking about skills, tools, and techniques, it's more about acceptance and tolerance of distress. It's not so much about the more classic, I guess, coping skills that you would think of. And then also creating a plan. So you also want to reduce shame with vulnerability. So this is very important with this population. So do not be afraid to talk about or ask about taboo topics, especially because intrusive thoughts that reflect cultural taboos can be isolating, and a lot of their thoughts tend to come with shame. So, encouraging them to be open about their experiences and thoughts can be really powerful. And like I said before, ask questions, especially because it's difficult for people to directly articulate the content of these thoughts. And so asking questions can kind of help them with that. And then lastly, learn to sit in distress. So, communicate distress is okay. It doesn't last forever. ERP, which we're going to talk about in a moment, is all about learning to sit with distress. And a big part of that too is being aware of your own distress about someone else's distress. So resist providing them with reassurance, especially if it's just because you're anxious and about their being anxious. All right, importance of talking about suicide with harm OCD. So talking about suicide and harm is necessary for many reasons. So it's helpful for evaluation and intervention. It's helpful for identifying obsessions and being able to help both yourself and the OCD sufferer differentiate harm OCD from true suicidality. Talking about suicide and harm is also a form of exposure. It helps with thought action fusion and disconfirmation of that. It helps decrease feelings of shame regarding taboo thoughts, and it increases awareness of senselessness or silliness of thoughts. So an example of this is, being able to say something out loud. It sounds very much in one's head as very big and bad and hard and scary when it's in someone's head. However, when they say it out loud, oftentimes people will say, wow, like that sounds really stupid, or like, why do I think that's going to happen? And then lastly, remember that encouraging your patient to talk about or think about these things, especially during session, like that does not decrease the risk of suicide. All right, so exposure and response prevention therapy. So exposure and response prevention therapy and medication is the gold standard for treating OCD. And with harm OCD, you can kind of think of it as a moral compass that's maybe bent in a really perfectionistic direction. So thinking of exposure with harm OCD as someone's going to feel less moral in the moment when they're doing exposure. However, they're probably still landing somewhere in the decent side of moral behavior. So another way to think of ERP for harm OCD is readjusting the compass by retraining someone to behave non-compulsively. So with exposure, especially with harm OCD, it's most effective to do both in vivo or in life and imaginal exposures. So in vivo is exposing oneself to real life situations and triggers. And then imaginal exposure is created stories about feared events. So these could be read, they could be listened to. And that's basically telling yourself a story of one of the scariest things you can think of without engaging in compulsions, mental or physical. So with response prevention, There's ritual weakening strategies which could be used. So that's even just kind of mixing up or making rituals or compulsions less automatic. So maybe you could tax it or delay or postpone or make them more awkward. And then also practicing not engaging with obsessions, especially if it's too difficult for someone at first to completely abstain from engaging in compulsions. And I'm going to talk about non-engagement responses in a minute. That's a helpful way to be able to do that. And then the proposed mechanisms for change for ERP are habituation and inhibitory learning. So habituation is basically just feeling less fear in the presence of the same trigger. And inhibitory learning is allowing the brain to learn to inhibit the fear response and allow other responses to also take place. But also, learning that, it's worth it, even though there might be a fear. There's also this new learning of like, even though it's scary, it's worthwhile and I can tolerate it. And then some quick considerations for ERP. Although ERP was created as something one can ultimately do on their own, it is really important to first engage in exposure with the guidance of a professional. It's also important to not automatically assume all OCD patients are doing ERP while in treatment. All right, so these are non-engagement responses. This is a good way to practice ultimately, hopefully not responding at all to obsessions. I kind of think of it as a stepping stone towards that direction. So non-engagement responses aid in acknowledging and accepting OCD thoughts and, helping with not engaging or arguing with obsessions. They help one stay in uncertainty without doing compulsions, and they're especially helpful with mental compulsions. So there are some examples below. There's 4 types. These are not all necessarily separated. They're kind of just separated because for help with understanding what they are, but they're ultimately meant to be kind of used together. All right, so regarding script writing, a moment. An imaginal exposure script can be thought of as doing an exposure in one's mind. It's writing one's worst case scenario. It's fairly detailed. And these are created and used in different ways, such as making audio recordings, which loop, reading it on a piece of paper, and it can also be used alongside in vivo exposure. So an example is like listening to a script of you harming someone while sitting next to a knife. Then there's acceptance and motivation scripts. Those are a little bit different. They can still be exposure, but they're more motivational. They tend to be more focused on standing up to OCD and investing in life instead of living in fear. And these help with promoting acceptance of unwanted thoughts and uncertainty. And lastly, coping scripts aid in helping people resist compulsions, and they utilize self-compassion, and it also can be an exposure. All right, so I want to just note that I have a few examples in here of scripts, and some of the content might be disturbing. So for those of you who might not necessarily want to hear that, that is okay. Maybe mute or fast forward or whatever it is you need to do, or you could hop off. Okay, so writing an imaginal exposure script, this is how you do it. So these are the key points of it. It's 3 to 5 minute narrative, first person tense, describing what you fear might happen if you don't neutralize. These are all of the ways to do so. That's the template. I'm going to move forward. So I'm going to give an example of that in a moment though, but I'm going to move forward to the next script. So the acceptance and motivation script, I'm going to give an example of this as well, but key points of this is it's a way of standing up to OCD and realizing, it is scary because it could possibly result in one's fears coming true. However, there's also a focus of investing in life instead of fear and promoting acceptance and, acceptance also of if you stay the same, what that means. And that means typically living as a slave to worsening OCD. And it's just a really good reminder of why it's worthwhile to change your behavior or one's behavior and accept uncertainty. It also includes values, which I like. And then writing a coping script. This is the template for that. Those are the 3 different parts of self-compassion. So mindful statements, so being objective and non-judgmental, and statements of common humanity and statements of self-kindness. I'm going to have an example of the coping statements as well. All right, so I'm going to really speed forward because we only have a few minutes left, but I'll go ahead and just share. So these are some in vivo exposure examples for someone who might fear having a harmful identity. So visiting people or places that are triggering, watching triggering things, reducing unnecessary safety behaviors, reducing checking behaviors. For the next. So this is an acceptance and motivation script example. I separated it just so that way it's easier to see the different elements of it. So the first part is I'm going to start barbecuing in the backyard and will limit my checking of the propane tank to only 1 time. So that's answering the question, what behaviors am I going to change? The second part, this may result in me leaving it on somehow and later causing an explosion that sets fire to my house and kills my family. I may realize that this happened because I was not vigilant enough, and I may spend the rest of my life mired in regret. That's answering the question, what unwanted consequences am I risking? The next part, but if I continue to avoid using the grill, I will continue to foster resentment from my children and further strengthen my OCD to the point where I can't use anything that involves fire. I'll devote huge portions of my life to checking and I still won't get a guarantee of no harm. That's answering what is the likely outcome of continuing to obey your OCD? And then I want to be the kind of parent who grills hamburgers and celebrates outdoors with his family. I believe that a good father is a present father, and even though there are so many things that I can mess up, it's still worth it for me to take the risk of standing up to my OCD. And that answers, what do I value that makes it worth it for me to fight my harm OCD? I'm going to skip forward. You're more than welcome to read this later. The next part is fear of harming others, in vivo examples, so doing things one might avoid, going where weapons are, including the store, watching things, playing video games. I'm going to move forward with this. This is another example you can read later. And I'm going to skip through that one. All right, exposure for fear of self-harm, in vivo examples. So bringing on thoughts, that's important. Being alone, gradually increasing the time one spent alone. Those are especially important for self-harm exposures. The next is an acceptance and motivation script for fear of self-harm. You can read that at a different time. Okay, so now I have an example of a coping statement for someone who fears self-harm. So it's again separated in the different categories. So I am having a lot of intrusive thoughts today, and I'm afraid I'll snap and hurt myself. That's a mindful statement. Many people would find thoughts of self-harm disturbing and be frustrated by them intruding. That is an example of a statement of common humanity. And I am doing a decent job of resisting overt compulsions right now. I need to give myself permission to view this as something I'm still working on and invite myself to write an exposure script and then reward myself with a good jog. That is an example of a statement of self-kindness. All right, in vivo exposure for harming children. Here are some examples. Doing a lot of stuff with children. Moving on. This is the last example. So this is an imaginal exposure script, and I might have to cut it a little bit short if we don't have time, but I separated it again in the different template questions. So I am playing with my 3-month-old baby boy, Aiden, who I love so much. We are smiling and laughing as I pick him up and set him down repeatedly. Suddenly, I think I could choke him to death. A wave of fear comes over me. I'm afraid to have my hands on him, and OCD tells me to put him down, but I refuse to let OCD rob me of this time with him, so I just keep playing. So that's the first part. Second part, my heart pounds, my breathing is fast and shallow. I feel dizzy and hot. OCD continues to attack. What if I actually begin to choke him? Am I capable of something like that? I envision my hands around his throat as he looks up at me, terrified and gasping for air. Oh my gosh, am I enjoying this thought? I think I am. I think the sides of my mouth are turned upward in a smile. Does that mean I might get sick pleasure out of choking him? Could I be such a monster? As terrified and uncertain as I feel, I just nod and agree with the possibility of every thought and imagine that comes my way. The next portion, I want to tell my husband the thoughts and images are worsening. Maybe it's getting to the point where I shouldn't be left alone, home alone with Aiden anymore. Maybe I am crazy. Maybe I am dangerous. OCD urges me to confess my worsening thoughts and to seek his reassurance, but I refuse and stay the course of treatment. Last part, which is the worst case scenario coming true, because remember, this is an exposure of the worst case scenario. I eventually lived to regret that decision, but the lesson is learned too late. Shortly after my husband left for work one morning, I choked my dear little Aiden. All of the news stories depict me as sick, unfit, deranged, and dangerous mother. I can't say they're wrong. I may be locked up in a psychiatric hospital for the next several years, and I wouldn't blame my husband for divorcing me and never wanting to see me again. All right, the next few are a few more script examples, and then we are now at resources for further learning. I highly recommend Overcoming Harm OCD. It is an amazing book, which I used a lot for this. It's great. And then my references. Thank you all so much for coming.
I know we ran out of time for questions, but if you do have questions, because there is a lot of content here, or if you'd like the slides, please put those in the chat and I will get those to Kelly and we will get back to you. I will be sending out slides later today or tomorrow for those that have requested them. I'd really like to thank Kelly for the very informative presentation today. Thank you all for attending Grand Rounds today. Please remember to return your completed evaluation form to me within the next 7 days in order to receive continuing education credit. Our next Grand Rounds will be on November 13th. Dr. Lori Walter will be presenting on treatment contracts to address dangerous acting out behaviors in the outpatient setting. Please look for an invitation in your email soon. Thank you again for attending and have a great afternoon.